episode of Naloxone Nation, a mini docu-series by the American Psychiatric Association, where our mantra is treatment anywhere by providers everywhere. I'm Lief Fenno, I'm a psychiatrist, and today we have the pleasure of speaking with nurse practitioner Laura Blakely. So you're a mental health nurse practitioner. Can you just break down exactly what that means?
So there's two paths into it. You have to have a registered nurse license, minimum of BSN. The programs that you enter, either you can start without that and have an accelerated program, which is what I did. In my case, I have to have a supervising physician, an attending who agrees to take on a nurse practitioner in a supervisory role. I have an allied health team where I'm partnered with a LCSW, so a clinical social worker, and also an LPC counselor who work on my team with me, and we collaborate on all of our clients together to make sure that they're getting case management and therapy services.
I'm curious, in the patients you see, Laura, are they coming in concerns just about substance use or also about mental health conditions, or both?
So typically it's both. Criteria for admission to our program is that they do have dual diagnosis. Our program really aims to be a holistic treatment in which we're treating the whole aspect of the person's experience and their mental health. Our program is really geared toward treating both, and our clients really come specifically for that treatment.
And sometimes they might struggle with substances in addition to opioids.
So we also treat other co-occurring substance use disorders, such as alcohol use disorder, stimulant use disorder, benzodiazepine sedative hypnotic use disorder, which is another pretty major one that we're finding pretty frequently. So while the opioid use disorder and primary mental health condition are the necessary diagnoses to get you in the door, that doesn't mean they're the exclusive diagnoses being treated.
And how do you discuss addiction with your patients, substance use disorders with your patients?
But I try to frame it in a way of chemical coping, and then sort of explaining to them that it does change your neurophysiology. It changes the way that your brain is working. It changes the way that your brain responds to certain stimuli and how behaviorally you respond to those stimuli. And trying to normalize that it's not necessarily always conscious, but it is a ingrained behavioral trait and chemical need that your body has sort of learned and that your brain has adapted to. And trying to frame that takes the pressure off of this expectation of perfect sobriety in order to be okay.
You mentioned this concept of harm reduction, and I was hoping you could say a little bit more about what that is.
Harm reduction means we know that people use. We accept that that's a reality that we can't force people to change, and that encouraging or offering them opportunities to use in a way that is less hazardous to their health and their well-being can still promote really positive outcomes. And the harm reduction, obviously the goal would be using much less or not using at all, but realizing that that's not the goal for every person. And you can promote their health and wellness by helping them find ways to use safer or less amounts of substances. In our view, any progress towards the patient's goal is a positive outcome.
You mentioned this concept of patient not knowing that they were taking a substance. Like, how could that even come about?
Our understanding is that when people are preparing various drugs, they're preparing them all together in the same area, warehouse, table. You can get cross-contamination, and there is times where they are adding other drugs to various batches in order to enhance or change the effect.
It seems like it could be incredibly dangerous.
It's extremely dangerous, and I think we're finding more and more that people who have been sober for a while and had a relapse and started using, or have come out of the correction system or incarceration, they've heard about this being a thing, but they're not fully aware of the severity of these instances happening, and so we do see more unintentional overdoses.
So what is it that people are overdosing on?
We are seeing a lot of unintentional fentanyl overdoses, as everyone's sort of been talking about. There are people who are intentionally taking fentanyl, and the concentration of their fentanyl is higher than they expected per dose. And how that happens, is kind of unclear based on the bat. But you're also seeing, cocaine laced with fentanyl or mixed with fentanyl on accident, pressed pills containing fentanyl. But you also are seeing stimulants making their way into other things. It's very common if you're going to take MDMA that you're going to also be taking methamphetamine at the same time. If you're going to take cocaine, often that's cut with methamphetamine as well. Oftentimes these cheaper, really potent drugs are getting added to more of these niche designer drugs to promote an effect. Benzodiazepines are also another great example, where many of the benzodiazepines that people believe they're taking are either a pressed pill containing fentanyl and the actual benzodiazepine.
How does naloxone play into your treatment?
So naloxone is something that we offer to every patient. We have it here in the clinic to give to them before they leave. And it's also something that I prescribe with every prescription of Suboxone. I usually write a 6-month supply at a time for them to pick up either once monthly or whatever their insurance allows. And we go through it. Do you know how to use it? Do you know how it works? Do you know what to look for when the overdose is resolving? Do you know that you need to continue to give it over time? It is now over the counter as well, and so I make sure to educate them on that that's an option. My goal is either they get offered it every time they go pick up their Suboxone prescription, or that they know that they can ask for it if they're running out.
How do you talk about buprenorphine with your patients?
Most of my patients come in with the goal of buprenorphine, but some of them are very ambivalent about it. Some feel that they don't really need it, or their family is very much against them taking it, feeling that it's just another form of drug use, or they feel like they only need it for a little while and want to come off of it because they just need a little bit of help. So I talk with them about how the medication works. I explain to them, yes, it's an opiate, but the effect that you get is really not the effect that you would expect to get from something that gets you high. It's more like something that just keeps you in balance. Your body is getting its needs met. It is a tool. It's neither inherently good or bad. It is just a thing that's helping sustain your body.
And what's a typical patient experience taking buprenorphine? You mentioned that it doesn't give euphoria. How do people take it?
Buprenorphine is sort of exclusively absorbed through the mucosal membranes, so they have to allow it to dissolve. There's different formulations. Most people tolerate it quite well. Biggest observable effect that people say that they know that they're having a medication in their body. Otherwise, people typically say, I feel better with this medication, but I don't feel like I'm on medication. Cravings are lower. They don't have breakthrough withdrawal symptoms. They feel more in control. Their anxiety is better. As their neurochemistry has been stabilized, they feel more at ease, more in control, like their day-to-day is back to what they remember it sort of being pre-substance use with regards to opiates.
You mentioned there's a formulation of buprenorphine that contains naloxone, but naloxone's also the reversal agent. So what's going on there?
People often get confused by why that would be in there. Wouldn't it undo the work of the buprenorphine? And so the naloxone has been included initially due to initial fears of buprenorphine being melted or dissolved and injected. So they included the naloxone so that it would basically negate the work of the buprenorphine if it was injected intravenously. Now, absorption through the oral mucosa means that it's not well absorbed at all. The buprenorphine alone gets absorbed and gets to be active in the body, and the naloxone sort of harmlessly falls through the body.
Is there any patient populations that cannot get treatment for opioid use disorder?
Classically, we say if somebody has an opioid use disorder, you treat it. From a treatment perspective, don't want to automatically deny anybody treatment for opioid addiction because the risk of being untreated is so high. If somebody has an opioid use disorder, the safest thing to do is to treat it and to not exclude them from treatment.
Even patients who are pregnant are able to get treatment for opioid use disorder.
We strongly encourage it. We start a plan. We talk thoroughly with the expectant parent to talk about what kind of things are necessary during treatment. Following with either maternal fetal medicine or closely with your OBGYN will be necessary in order for us to feel, sort of confident moving forward with treatment, but not even everybody can do that. So making sure that we put as many safeguards in place as possible in setting expectations and making sure that the hospital where they will be delivering is aware that they're on Suboxone or methadone, so appropriate steps can be taken when the baby is delivered to make sure that they're appropriately monitored and cared for.
What do you enjoy about being a provider who treats both mental health conditions and substance use disorder?
I love my job. I love what I get to do. I think the best part is when you are treating people who are vulnerable and in these positions like I am, is when you treat the substance use disorder with the mental health condition, is you really get to see people make progress in a way that you don't get to see in a lot of other settings, and you get to develop really personal relationships with your patients.
Thank you so much for your time, Laura, and inviting us into your clinic, your office, and telling us what your practice is like and how you work to treat substance use disorder. You really embody the Naloxone Nation idea of treatment anywhere by providers everywhere. And thanks to everyone for tuning in. Again, this is another episode of Naloxone Nation, a docuseries by the American Psychiatric Association.